Okay, let's start with a review question before we finish up here. What diagnostic test would you use to detect the presence of Ebola antigens in a patient sample? Is it A, an antibody capture ELISA, B, an antigen capture ELISA, C, PCR, D, RIFLIP, or E, QRT-PCR? Go ahead and pause the video. Think about this one. Okay, hopefully this was easy to figure out from the name. We're looking for Ebola antigens. A great way to detect those would be an antigen capturing ELISA reaction. Remember, we put antibodies in there that grab onto those viral antigens in that case. Okay, so we're going to talk about what we call point of care rapid diagnostics. We'll talk about some important terms to test these things, specificity and sensitivity. We'll do a basic overview of what we call immunochromatography assays, which are essentially those rapid test sticks, kind of like a home pregnancy test or a rapid COVID test if you've used one of those. And then we'll talk about the advantages and disadvantages of these techniques. Rapid diagnostics are awesome because tests that can be done quickly, right where a patient is seeking care, can do a lot of good, right? We can get very quick results, and this helps us because the patient is still there, right? A lot of times when you do other diagnostic tests that take a day or more, we have problems with patients not following up. Again, this harkens back to human nature, right? People are busy, lazy, whatever you want to describe it as. If we can do something instantly, that's way better than if we have to wait. It can also be very reassuring to people if the test comes back negative. It can also be reassuring that something can be done if it comes back positive in some cases. So hopefully you're familiar with the COVID antigen test. You place a sample in here and it goes through. There's a control line and a test line, and we can tell if someone has COVID-19, SARS-CoV-2 virus antigens in them. Also, kind of another rapid point of care test would be something like a blood glucose test, which is very important for diabetics, right? These tests have some drawbacks. We have to design them properly. And oftentimes we sacrifice some things in the pursuit of speed, right? So we have to look at sensitivity and specificity. These are two things that we're going to look at when we analyze new diagnostic tests. So sensitivity is described this way. If a patient has a disease, so they are positive, how often will the test be positive? That's a measure of sensitivity. So we know they're positive. How many times is it, I guess a better way of putting it, is it not picking up that they are positive, right? The higher the sensitivity, the more it will pick up that they are positive, right? 100% would be every time it correctly identifies it. 95% sensitivity would mean that 95 out of 100 positive individuals get flagged as positive. So that means there are 5 people who get a false negative out of that. For the other term, specificity, if a patient does not have a disease, how often will the test be negative? This is specificity, right? If we get a positive result when they are not infected, that is low specificity, right? So if we want to get negatives when they don't have it, 100% of the time would be 100% specificity. If only 95% of the time when people are negative, we get a negative result, that's not great. There's still 5 people that are getting a false positive in that case. These tests, particularly sensitivity, can reflect how small of a concentration of microbe or antibody or antigen they can detect. So sensitivity often has limits, and sometimes when people are very early phases of a disease, some of our quick diagnostic tests are not sensitive enough to detect them. PCR is one of our most sensitive ones because it can find even just one molecule of DNA in there. Okay, so let's put this in other words just to reinforce it. If we have low sensitivity, this is going to require a large amount of antigen in the sample. Otherwise, it's not going to be enough to detect. That would give us a false negative, right? So if the person is infected but they don't have enough antigen for the test to detect that, they would show up negative, even though they are indeed positive. When these tests are being designed, they actually do clinical tests where they measure the sensitivity, and there are certain cutoffs, right? Sometimes this is limited to certain sensitivities for certain diseases, but oftentimes we're willing to sacrifice a little bit of sensitivity for the speed of the test. In the case of specificity, it's how well it distinguishes one antigen from another antigen. Tests for the Mycobacterium tuberculosis antigen should only be positive for that antigen and not other Mycobacterium species like Mycobacterium leprae, right? That's an example there. If a test is less specific, it might show positive even if we have other antigens in there. That gives a false positive in this case. So again, we can test this, and ideally, we want the maximum sensitivity and the maximum specificity. But again, we don't always get that. We sacrifice these things for speed, right? If we can do this in 15 minutes instead of a day or 2 days, that is awesome. So we'll sacrifice a bit of that for rapid testing. Oftentimes, though, this leads to needing to follow up with a second set of tests. So sometimes if we get a rapid test that shows up negative, we have to confirm that with other results. So like if somebody is suspected of having Streptococcus pyogenes, which can cause strep throat and things, a rapid antigen test that is negative when they clearly have symptoms that look like this generally need to be confirmed with another method, something like that. If we see a malaria positive, particularly in the United States, we tend to want to confirm that one because the possibility of it being a false positive is high because there's not a lot of malaria in the United States. So let's look at how these test strips work. These work on principles called chromatography, which means color, but it really means color moving through a piece of paper, basically. And they rely on antibodies. So let me just describe what the test is. Let's take a COVID-19 test, for example. You swab your nose and you put it in a little solution, and then you put some drops of that solution in the little well here. And that liquid is going to run through this test strip. There are two little lines of antibody on this piece of paper. One is called the control line. That's there to show that the test is indeed working, even if it is negative. Then there is the test line. That is showing us negative versus positive. If the control line doesn't show up, the test didn't work at all. There was some failure, maybe it's old or something like that. If we get a control line and a positive line, then the person is positive. If we get a control line and no positive line, person is negative, at least given the sensitivity that we're talking about. So how does this work? For this test strip, we're looking for the presence of the bacteria S. pneumoniae, which can cause pneumonia. So we have a pool of test stuff. So we took a swab and we extracted that and we dropped that in there. There might be antigens in there. We also have a special type of antibody. This is anti-pneumococcal, so anti-pneumonia, S. pneumoniae, labeled rabbit polyclonal antibody. So it has a little a gold molecule on it, and it's a rabbit antibody against this bacteria that is floating around here. And if the antigen is there, it will bind to it. On our test line and on our control line, we have two different types of antibodies. On our test line, we have anti-pneumococcal rabbit polyclonal antibody. So the same thing that's floating around, but it's bound to this line. On the control line, we have what's called goat anti-rabbit IgG antibody. So this is a goat antibody that will recognize any rabbit antibodies. Okay, so what happens? We drop our sample in. If there is the S. pneumoniae antigen there, it will flow through this paper to the test line. There, the bound antibody and the floating antibody that is in this part of the test strip will bind and make a sandwich with that antibody. That results in a color reaction, which causes the line to turn whatever color, pink or black in this case. As the rabbit antibodies that are free floating flow through, they will reach the control line. The control line has the goat anti-rabbit antibodies stuck to it. So it is going to bind any free floating antibodies of the rabbit one, the test one. That shows that everything flowed through. We bind these free floating antibodies. That shows that the test actually made it all the way out here and that it did indeed work. There are no problems with it. This test line, if it was negative, no antigen would be bound. The color would not show up because these would just keep floating on by and get caught by the goat one. Okay, so that is exactly how our COVID-19 rapid test works. This is all based on sandwiches right here and antigens and antibodies against antibodies. So if you need to review that, you can read the description here. It might be a little bit better than my words. But these are pretty fascinating, right? Because we can do this in 15 minutes and get results. Whereas a PCR, you got to go somewhere, wait day or two, right? The PCR can be done quickly, but the realities of running a PCR, you can't just do one reaction. You got to wait until you get many to do them all at once. There are several commercial point-of-care tests. Here's a smattering of them. We have a lot for sexually transmitted infections: chlamydia, Neisseria gonorrhea, syphilis. You can use urine for gonorrhea. Chlamydia, you could use a vaginal swab or urine. Syphilis, you could use blood. And you can see their sensitivities and their specificities here. You'll notice that the syphilis one, not great. We go down here to Legionella, which can cause Legionnaire's disease, causes pneumonia. It's only got 77% sensitivity. So that's not great. It has 99% specificity. So, but still, what? 13 people out of 100 roughly are going to show a false negative in this case. So again, it's not perfect, but it is rapid and can help us more than it's going to be negative here. Here's some ones for viruses. Influenza, we have SARS-CoV-2, that's not listed on here. Wasn't able to find the statistics on that one, but you could go look it up. We have one for HIV that is very sensitive and very specific. Obviously, this has been very well designed because we definitely want to be able to identify HIV in fluids, particularly if we're dealing with patients where we're not sure if they might have HIV. Other ones, not quite as good. Rotavirus, you will see that I guess the less common or the less dangerous they are, we're willing to accept a little bit less sensitivity there. Why are these great? Well, as I've said, they're fast. They're really easy to interpret, right? We can see a line or no line. So with some rudimentary training, I can teach pretty much anyone how to use those. We taught my wife's parents how to use them, and they're not scientists, so we explained what was going on, and it makes more sense when you know, but even if you just follow the directions, you can quickly tell what's going on. You don't have to do any culturing, right? You can, if you're testing for something, you could immediately, if you're a clinician, prescribe the correct antibiotic or antimicrobial. And that can help patients avoid taking unnecessary antibiotics, particularly like if it's a viral infection. You can also quickly determine a chain of infections in patients with similar symptoms. You could look at a whole family and determine, are they all infected? And you can directly notify someone that is sitting in a waiting room because once people leave a clinician's office, right, they can often be hard to reach, and that could lead to an outbreak or something like that. There are other more advanced techniques, PCR, chamber type things that are rapid PCRs. These are very specialized techniques. We're not going to get into how they work because, frankly, it's kind of complicated. But there are other techniques for like rapid PCR as well. The disadvantage of this, right, if we're getting a specific pathogen there, without doing the growth and the antibiotic disc test, we don't know anything about a pathogen's antibiotic sensitivity, right? We just know they have a pathogen. We don't know if it's a specific strain of that pathogen. There is an increased risk of technicians or nurses or whoever's doing the test becoming infected because you are handling a sample from someone else that would normally be taken care of in a lab. So understanding proper procedures for taking these samples and processing them is key. Also, we can often overlook infections that are the result of multiple organisms because if we get a positive line for like E. coli, we might stop looking for other bacteria. So if we get a positive in the initial test, we might not look for other microbes in there. Pros and cons to these. They are great in some aspects. They have some downsides, but we can easily counter those if we know what the disadvantages are. All right, I think that was a cool chapter. Hopefully, you learned something about how those tests work. Home pregnancy tests work the same way. They're just looking for different hormones. And this all relies on immunochromatography, right? We have sensitivity and specificity. I would like you to know those terms there and know some of the advantages and disadvantages here. All right, we're going to finish up with one review question just to get your brain working. So we have a diagnostic assay that gives a high number of false negative tests. This has low which of these? A, sensitivity, B, specificity, C, antigenic variation, or D, selectivity. Go and pause the video. Think about that one. All right, in this case, high number of false negatives means low sensitivity. You can go back and review that. That is it for chapter 25. We have one more chapter left. Bye for now.